Well, good evening, my friends. It is that time again. Top of the hour. It's 5 o'clock Central Time, which means it's 6 o'clock on the East Coast and four in the mountains, three on the West Coast, and it is time for Fertility with Fink. I'm Dr. Randy Fink, live from Pensacola, Florida, where I am a fertility gynecologist at New Life Fertility. I also do some work at the Missouri Center for Reproductive Medicine, MCRM, in St. Louis. We have offices here on the Gulf Coast in Mobile, Alabama, Pensacola, Florida, and as always, this is the place we are every Tuesday evening, where we get together to talk about all those things that are important to us, things about making a family, things about gynecology, things about women's health, and things about whatever is on your mind. And I thought tonight might be a really good opportunity, since I've been getting a lot of questions kind of recently about things hormonal. And so maybe you saw my post that I thought we could really try to address some hormonal issues tonight, answer some questions about hormones, and see if we can't clear some things up for you. Maybe you'll find some interesting things here. I can't decide whether I should go with glasses or without glasses. Either way, I think I'm going to go without glasses because I'm just crazy like that, you know. Happy Tuesday to all my friends who are joining here tonight. We've got Facebook and LinkedIn and YouTube over here. We've got my Instagram feed, which is Randy Fink MD, and we've got New Life Fertility's Instagram right here. And let's say a special hello to Shada. Nice to see you. Hi. Looks like Carl or Carliston Kraus, I believe that says. Rosa, thank you for your kind words. Hi, Marlena. Amber is here from Gulf Shores, and so is we've got Bryn joining the program tonight. So again, thanks for all you guys being here as always. And let's kind of dive right in and start to talk about really some of these hormonal questions and what's kind of going on inside the body that leads to some of these, really offensive hormonal side effects. When I was practicing as a general gynecologist, I would often, hear from people things like, "Oh my God, my hormones are driving me crazy," or "Oh my heavens, because of hormones, I am gaining so much weight," or "Because of hormones, my car battery just died. Because of hormones, I need to get new tires and the country is losing the war." Everything gets blamed on hormones. And sometimes hormones really do have something to do with it. But in many ways, it's kind of become a convenient way for people to sort of point the finger at generally not feeling well. And while there may be some hormonal component to that, it's not always hormonal, although a lot of times doing things with hormones, we can generally kind of make you feel better. So, maybe there is something to it. The first thing to think about is sort of what's going on inside your body hormonally. And everything in a woman's body goes back to the menstrual cycle. So in the reproductive years, really the whole thing with the menstrual cycle is just what does it take in order to get pregnant? So in the beginning of the menstrual cycle, the brain talks to the ovaries and says, "Give me a bunch of eggs." And the ovary says, "Okay, I can do that." And so it dips down into its well and it pulls up some eggs. And these eggs hang out in the ovaries and tell the brain, "Okay, yep, we're ready to go. Just tell us what to do here." These eggs will start fighting with one another, and almost literally, that's really what they do. They fight with one another because they are one of them is going to emerge as the egg that gets released. That's the one that gets ovulated. All right. So what happens there hormonally is that egg starts to grow. It starts to make your estrogen. Estrogen is kind of the key woman's female hormone. Estrogen, it's what makes you female. Estrogen stimulates the lining of the uterus to grow. And what we're looking for there in that lining of the uterus is that we're trying to get a nice, thick, warm, spongy, juicy place for a baby to implant. at the middle of the cycle. So as that follicle in the ovary, and that's like the little egg house, starts to emerge as the one that's going to gets released as it approaches the time of ovulation, you're making more and more estrogen. That little egg is surrounded by some cells. The cells are called granulosa cells, and those cells are what make your estrogen. Estrogen stimulates the lining to grow. When the egg gets big enough, the body has a surge of what's called luteinizing hormone, or LH. And if you've done urine ovulation predictor tests, then what you're doing is you're testing for that LH hormone in your urine. And the egg gets released from the ovary when it becomes mature. So the little space that gets left behind goes from being an estrogen making factory to being a little progesterone making factory. And progesterone is really hormone number 2. The purpose of progesterone, progesterone, is to maintain a pregnancy. And so that area inside the ovary, it's actually a cyst. It's called a corpus luteum cyst, and this is called the luteal phase of the menstrual cycle. Is that those cells are making your progesterone, and that's what it compacts the uterine lining and makes it ready for implantation. And it's that progesterone hormone that causes the pregnancy to continue to grow. So everything really in the body is predominantly based on what's happening with your estrogen and progesterone. So certainly as it pertains to pregnancy, we know that to be true. So when you're undergoing fertility treatments, we're doing things with your estrogen and your progesterone. We're looking at those numbers. We're probably giving you a little extra estrogen and progesterone. So estrogen and progesterone, that's the key. But you also have some testosterone in your body. Testosterone, classically people say, oh, but that's the male hormone. Well, I mean, yeah, it is a higher hormone level in men. However, it is most definitely in women as well. So what else? We've got some cortisol in there, which is the body's stress hormone. We've got lots of little hormonal systems that are functioning. Hormones are messengers that are sent to do something that our body needs to have done. So that's what a hormone is. But so what's happening with all this business? Acne, for instance, is a very common thing to happen in the menstrual cycle, especially as you start to, approach the time of your period. And why is that? Well, if you've got polycystic ovarian syndrome, do you have acne? Do you have excessively oily skin? Is one of the questions that we usually ask. And the reason for that is because oftentimes women with PCOS have a little higher testosterone level, but you can have completely normal testosterone levels and still end up with acne at that portion of the cycle. Why does that happen? Well, what did we just say? In the second half of the cycle, or in what we know of as the luteal phase, your progesterone hormone becomes high. The progesterone is high because it's trying to maintain a pregnancy. Now, what causes you to have a period? If the body realizes that there's no pregnancy there, the progesterone level drops off. And that dropping hormone level is what stimulates you to have your period. All right. And so when you take a birth control pill, you're getting levels of hormone that are here until such a time as you reach the end of the pack, the levels drop off, and that stimulates you to bleed. So it's really that same thing is going on there. But progesterone stimulates the activity of the sebaceous glands in the skin. Sebaceous glands are oil glands. That oil in our skin is really necessary in order to lubricate the skin, to protect the skin. As we know that those follicles in the skin some hair follicles and pores can get blocked. And bacteria can start to grow in them. And that's sort of what leads to pimples and acne. And in fact, while progesterone is stimulating those sebaceous glands. It's also causing a little puffiness in the skin, which can make the pores more prone to getting blocked. In addition, as we reach the time of the period, right, all the hormone levels are dropping off at that point, right? Everything is kind of going down because if the body realizes it's not pregnant, hormone levels drop, and that's what stimulates the period. Well, as the estrogen levels start to drop, so we already said progesterone has caused an increase in the secretions, those oily secretions in the skin, and some puffiness in the pores. The estrogen, as the level drops there, causes a relative excess of the testosterone hormone. So it's not that testosterone levels get any higher. You can measure them in the blood, and they're probably the same at any point during the cycle. There's not really a lot of cyclic variation in your menstrual cycle, but because the estrogen has gone down, the testosterone is being seen by the body as being higher, and that testosterone increases the secretions from the sebaceous glands even more. It increases production in the skin, and that's what results in that hormonal acne that happens around the time of the period. Hormonal acne typically is along the jawline here. It may sometimes be along the hairline or here around the cheekbones. So that's the acne part. What about the effect on mood? How does the hormones, my hormones are going crazy, my moods are all over the place. And it does also, beg the question about, well, where does PMS really come from? You say, my estrogen is so out of whack. Well, actually, estrogen is probably the good guy in this scenario because estrogen causes a secretion of serotonin. Serotonin, we know, is sort of the mood stabilizing hormone. So antidepressants are typically selective serotonin reuptake inhibitors, SSRIs. Their job is to increase the serotonin that's in the brain. So estrogen is causing you to make more serotonin. That happens through an enzyme that's called tryptophan hydroxylase. So more serotonin means more receptors. There's more receptors for that serotonin. There's more dopamine activity. Dopamine is the feel-good chemical in the brain. And so that leads to stability. Typically people feeling normal, feeling good, right? But then what happens? You ovulate, right? And the body starts to make more progesterone. And that progesterone can start to really kind of mess with everything. Progesterone increases progesterone acts at the level of the brain on the GABA channels, which are the GABA channels are what helps to keep us calm. So as the cycle wears on and the progesterone levels start to drop down, the effect on the GABA channels is we lose that calming effect. And in fact, as the estrogen starts to drop in that second portion of the cycle, we start to lose some of the stability from the serotonin. And that's what leads to the PMS. Now, there's different forms of PMS. There's PMS, there's PMDD. Call it what you will. People can actually be really very disabled by these mood-related changes, but that's what's happening with estrogen and progesterone, and why it's causing those mood changes. Also, as those hormone levels drop, your cortisol levels, which control your body's response to stress, those levels go up, and that can lead to some more mood symptoms there as well. And the other real common question is, well, what about my weight? Gosh, my weight gain, that's got to be something that's hormonal. And certainly weight comes from a lot of different places, right? Weight gain, or for that matter, weight loss is not a simple function of hormones, but the hormones do absolutely have something to do with, let's say, fluid retention. So the average woman who is cycling will gain anywhere from 1 to 3 pounds typically, or maybe let's call it 1 1/3 to 3 1/3 or 3.5 pounds of water weight. That's fluid retention alone during the menstrual cycle as a result of the hormones. Um, there are a lot of reasons for that, but it mostly has to do with estrogen and progesterone in terms of the way they act on the kidneys and the way they cause the kidneys to start to retain sodium and to retain water. And this leads to things like some of that weight gain. It definitely leads to some bloating. It definitely leads to some breast tenderness as well. So, at the level of the breast, there are two different types of cells that can be affected. There's the ductal cells and the lobular cells, and these both kind of respond a little differently. But as the cycle wears on, they both get stimulated, and it can cause some really very intense breast pain, which is what we call mastalgia. Cyclic mastalgia is the breast pain that is associated with the menstrual period. And so yep, it's definitely estrogen and progesterone driven as it pertains to diet and actual weight gain. Because again, that business on the kidneys, on the sodium retention, on what's known as the renin, angiotensin, aldosterone system is really based on really results in fluid retention and not so much the deposition of fat. But during the follicular phase of the cycle, which is the first half of the menstrual cycle, estrogen typically stimulates satiety, like it makes you feel like you're full, but it fights with progesterone, which is trying to increase appetite. So as you start to approach, let's say, the time of ovulation, you may find yourself craving carbs. Why is that? Because your progesterone level goes up when you ovulate, right? And so that leads to fat deposition most commonly in women around the area of the butt and the midsection. And that's really kind of because it's really better to have it there than to have what's known as visceral fat, which is being sort of deposited deep on the inside. Because the body is thinking, well, if I deposit fat around the midsection here, around my hips, or around my butt, then likely what's going to happen is that I can burn that off easily. That's a great place to store it in case of stress, in case I need it for the fight or flight response. And so, estrogen and progesterone, they're a necessary part, but it's by looking at what they're really doing at the level of the cells and as what's happening in the female body with the menstrual cycle, that we can sort of understand some of these menstrual related symptoms that are happening: the bloating, the weight gain, the breast tenderness, the mood changes, the PMS, and even the acne. So hopefully that gives you a little better picture of what's going on the inside. And that's something we're always happy to talk with you about, because it's by manipulating that system we can hopefully make you feel better. So there's my little hormone talk in a nutshell. And I haven't been ignoring all the folks who've been sending in some questions here. So let's say hi to BRNP, that looks like. Hi, Sheila. Mrs. Villarreal, nice to see you this evening. Big Boy Pants Golf, I like the name. That's great. Hey to Daisy in Miami, thank you for being here. Hannah, it's good to see you tonight. Gradle is with us. Hi, Stephanie. Lexi is there. Lexi, I hope you're doing well and that everything is stable and that you're feeling great. We're all very happy for you. Shandadanai, if I'm saying it right, I'm sorry if I missed it. Ruger, nice to see you there. Carly, howdy, I think we said hi before. Hey to Midgie, nice to see you as well. And Wendy. So let's dive into some questions. Hey to Katie, hello to Jay Palmero. Rosa asks, how long before a transfer should I stop breastfeeding? And do I need to suppress again with Orilissa? As I did this for my first transfer, I had a vaginal birth with vacuum assistance. Okay, so by the way, the vacuum assistance is a little suction device that goes onto the baby's head that just helps the baby to make those last few centimeters out around the corner there in order to get out, because sometimes baby needs to come out. It may be that we see the heart rate is starting to get affected by the birthing process, or it may be that mom's just tired, needs a little help to make that last just around that last corner. That's what the vacuum is for. So in general, we don't want you, Rosa, to be pregnant while you're breastfeeding. All right. So the American Academy of Pediatrics recommends that you breastfeed for at least a year if you can. Now, there are some people who don't want to breastfeed, and so we certainly don't browbeat people. It's entirely your choice as to whether you breastfeed, but we want you to stop breastfeeding by the time you do an embryo transfer for a couple of reasons. One, because we don't want you to be breastfeeding when you're pregnant. That's generally something we don't like. The outcomes are not as good. The embryo transfer success rates are lower. The miscarriage rate is higher, and you know what? It's just a challenging environment for the baby on the inside when mom is having to supply the nutritional needs to the baby on the outside as well as to the baby that's down on the inside. But secondly, the medications that we use for your embryo transfer can affect both milk supply and can affect baby. So we really don't want you to be on medication when it comes, kind of when you're breastfeeding. So how long should you stop? If you have stopped, then I think, really you're fine. If you're in the process of weaning, I would recommend, wean as best you can, because once you start those medications, it may help to dry up the breast milk supply. If you're doing a fully natural cycle, I suppose you could do it that way. But when that happens, ovulation becomes far less predictable. And so you're at much higher risk for things like getting a cycle canceled because your ovaries aren't doing what we expect it to do. So I would say, really the bigger question is, what's the optimum time to be pregnant after having the first baby through an embryo transfer? And the answer there is, I would say I wouldn't want you to you had a vaginal delivery, which is a good thing. I usually say at least 9 months. The studies say that when you have a baby between 1 and 5 years after having a previous baby, that's the optimum kind of number. So if you start to get pregnant at the 9-month mark, I think that's a very safe way to go about it. Now, the other thing to realize, and I should say that probably one of the reasons for that is that the only preventable risk factor for severe preterm birth is a short interconceptual interval, meaning to say that you got pregnant too quickly after you had the other baby. And that significantly increases your risk for severe preterm delivery. And obviously, that is something that we definitely wish to avoid, So, and the other piece to that is, should you suppress again with Orilissa? So if there's a question of endometriosis or BCL6, I think that the suppression that you did, generally speaking, lasts about 6 months. And so, yes, I would, and I do suppress folks again. I wouldn't test for it again. There's no utility in doing that, but I would do 8 weeks or 60 days of suppression before that next embryo transfer. Hope that's helpful there, Rosa. And I hope you're enjoying your baby, your well-deserved baby. Marlena asked, prolactin levels interest me. It said that elevated prolactin can cause ovulation dysfunction. That is correct, such as luteal phase defect. But at what cycle day would you want to test prolactin, because doesn't it vary? The answer is it doesn't vary so much by cycle day, but it can vary by time of day, and it can vary by whether you've eaten. And so usually what we recommend, so typically what happens, and I will say an elevated prolactin occurs in, I think the studies show anywhere from 20 to 30% of the patients who are walking into a fertility clinic. So the prolactin business is very real. And yes, it can absolutely mess with cycles and change the way the body is responding to the other hormones. But we just do a random prolactin. If it is elevated, then we say, okay, now we want to repeat it, but we want to repeat it fasting. We want to repeat it first AM. And I want you to do it without any breast or particularly nipple stimulation for at least 24 hours. So I remember in medical school, I had a professor who said that, even running up the steps with a bra that doesn't fit you well can stimulate prolactin and create an elevated prolactin hormone. So we repeat it. And if that one's abnormal, then we talk about, well, do we go ahead and treat it, or do we think about getting an MRI to make sure that there isn't a little growth specifically on the pituitary gland that's secreting that prolactin hormone? Either way, you typically treat it the same. If you use the medication, it causes the little growth on the pituitary to shrink down. But it's the kind of thing that you want to know so that you understand how you need to follow it. In Miami tonight is Zenaida, and a very special good evening to you, appearing on Facebook, I think. Oh, no, actually on LinkedIn, it looks like there. Usually I see you over on the Instagram side, so very happy that you could be with us tonight. All right, let's see what else we got here. Carly, it looks like Carly. Carly said, I had a miscarriage in September and a failed or a chemical pregnancy at the end of November. Should I just transfer again, or what testing do you recommend? I had a hysteroscopy in March and an MRI in May. All my other labs were negative. Okay. So that both of those situations, first of all, I would say I'm very sorry about the pregnancy losses, because those are, that's really pretty crappy to have to go through, to have to deal with the miscarriage and the clinical loss of the pregnancy, and then to get that positive pregnancy test, and then to have that disappear and go away when you were certainly so excited and enthusiastic. It's a tough thing for sure. And we're all sorry that you had to go through that. I'm going to answer that question for you in just 1 second, Carly, because what this reminds me of is that it's 5:30 here Central Time, but it's 30 minutes past the hour, which means it's time for the 5:30 Fuzzies with Fink. And what on earth does that mean? Yes, I'm fuzzy, but that's not what we're talking about here. Carly, in talking about your pregnancy losses there, I said, we are all here very sorry that you had to go through that. Just like each of us feels for each other one of us when something has gone wrong in our lives. So often it's easy to struggle with the realities of our day-to-day existence, with the stressors of life, with things related to not just fertility and getting pregnant, but things related to relationships, things related to jobs, things related to family, to the environment around us, to the world around us, to politics. Everything in the world that creates stress on us can really cause us to get down and to feel very much alone. I have always said that the folks who tend to come along to this particular broadcast are usually pretty special people. And I feel it very honestly in my heart that every single one of you who are out there tonight would pretty much do anything you could to help any other one of the people who are on this program tonight. And so that's what we do here at the 5:30 Fuzzies with Fink. It is about standing together as one community for everyone and anyone who is in need tonight, who is in need of knowing that they're not alone, who is just in need of having some good wishes sent their way. At this point, let's all take those good wishes and send them out to all our friends out there, not just the folks watching, but the people who couldn't make it tonight, to all the people in your lives who need that extra little pat on the back, that extra little bit of love, know that we are all sharing it together right this minute. And that is the 5:30 Fuzzies with Fink. We could break the internet with good wishes, and that's what I wish we could do. I end every program by saying every step forward with love and every step forward with kindness, because the world is really not a kind enough place. But every time I am stunned by how horrible people can be to one another, I am also really taken by how wonderful people can be to one another. And so I'm happy to be a part of that. And I'm really happy that you are here to be a part of that too. So our best wishes go out to every single one of you. And now, Carly, going back to the question here, what else do you need to do to kind of evaluate what happened there? Well, in most cases, a miscarriage happens because it's a chromosomal issue, right? That it's a genetic problem with the embryo, something that prevents that embryo from growing and that would make it unable to support continued life. And so nature has a way of ending those pregnancies so that they don't go on. It's a terrible thing to have happen, but honestly, it's better, realistically, it's better to happen at 6 weeks than it is to happen at 36 weeks, or God forbid, to happen at 6 years old, A chemical pregnancy is when we have that positive pregnancy test, which means that the embryo implanted, it just didn't continue to grow to the point where you could see it by ultrasound or recognize that you did, in fact, have an intrauterine pregnancy. That's what we call a biochemical pregnancy, and that is almost always a genetic issue as well. So, Carly, I'm not sure what you did in order to get pregnant. You said, should I just transfer again? So I'm taking that you did IVF. And so it makes me wonder, were they tested embryos? My hunch is probably not. So one option is to say, well, all right, and some of this also depends on how old you are, but you've done what you needed to do. Your hysteroscopy was in March. It's up to date. I'm assuming that you lost that pregnancy. You didn't have to have a D&C. I like to say, if you had to have a D&C, that we generally want you to, I like to look in the cavity again, just to make sure that nothing has happened there and that there's no scar tissue or anything really left behind. There are some, if you were going to transfer again, there would be some immune things that I would recommend that you do. And some of those immune things, just to say, well, we're thinking that this is an embryo issue, which in all probability it is, but is there a possibility that there could have been something autoimmune that kind of prevented you from that pregnancy from growing? That's possible. Endometriosis is always a possible consideration, and there's a non-invasive test you can do for that that's called Receptiva. The other particular autoimmune interventions I would certainly use for you would be tacrolimus or Prograf, because when folks have had recurrent implantation failure or recurrent pregnancy loss, we have to wonder, is the immune system trying to attack the pregnancy? And that's what tacrolimus helps to prevent. So those are just a couple of things, but I'd want to kind of take a deep dive. At the end of the day, most of the time, it's just an embryo issue. So what this does tell us is that, yeah, your body has the ability to do what it's supposed to do. It's supposed to implant a pregnancy, and that pregnancy is supposed to grow. So it knows how to implant. We're just having a problem with the growing part. So fingers crossed for you there, my friend. And Carly, I certainly hope that those good vibes that come from this whole group go a long way for you, my friend. Let's see. Shada says, Doc, have you ever had patients with endometriosis and adenomyosis that were able to carry their pregnancies to term? Yes. I had a laparoscopy and the outcome was stage 3 endometriosis and adenomyosis. Any recommended treatment? So the treatment for both of those things is, if you had surgery for endometriosis and had the endometriosis surgically treated, then that part is really taken care of. However, the issue is that that adenomyosis you can't surgically treat. Adenomyosis is that process where the glandular lining of the endometrium, that's the part on the inside of the uterus, starts to dive down into the muscle, and that creates some disturbance in the endometrium. It makes that uterine lining not function as optimally as it would. Now, how much does adenomyosis really contribute to fertility problems or the inability to carry? That's pretty controversial. There's not a lot of good evidence that says that, because of adenomyosis, you won't be able to carry a pregnancy. In fact, there are many who believe that adenomyosis is really just kind of a normal variant. It's something that happens to every uterus as we age, or certainly after childbirth. Now, in your situation with endometriosis and adenomyosis, the treatment of choice would be Lupron, would be hormonal suppression, because hormonally you're going to be treating the endometriosis, and you're going to be suppressing it. And I know, Shada, you did that before, but you did it with Orilissa. Orilissa is not as well studied in the treatment of adenomyosis, whereas the standard of care treatment, going back, decades and generations, was always taking the uterus out, but leaving the uterus in. The treatment for a generation has been Lupron. So I think it might warrant a consideration of some Lupron suppression instead of just the Orilissa. But here's the thing, as it pertains to the endometriosis, you may have heard me say before that endometriosis that we can see is really the tip of the iceberg. And so you can see the very best endometriosis surgeon ever, hands down, best surgeon ever, who peels out and removes every iota of visible endometriosis. But guess what's going to happen? You're still going to have some endometriosis, because what we can see is the tip of the iceberg. There's always going to be something that's still there. And so that's why I feel that endometriosis itself, unless you're having problems with painful periods and that sort of thing, the laparoscopy isn't necessarily so helpful. It has to do with suppressing what you have. And so next step up might be to think about Lupron if there's some concern there about adenomyosis as well. I hope you're doing well, Shada. It's really nice to see you back here. Haven't seen you for a while. Great Old says, are there any points in the IVF process where it's okay to get Botox? Yeah, you can really get Botox. Botox is not known to have some negative effect on egg quality. So I think it's fine to do if you're in a stim cycle. I have no reason to think that it's not. I wouldn't do it if you're planning to do a fresh transfer or if you're doing an embryo transfer cycle, because when you're just about to put the baby inside, that Botox can last in your body for a while. But if it's just doing an egg retrieval and making some embryos in the lab and then coming back a little bit later on to do your embryo transfer, I think the Botox is probably okay. Amber asked, how does it feel to be a man and not have this happen every single month? Well, I would say I'm in touch with my feminine side. It's that side. Let's see, any recommendations on an anti-inflammatory diet or lifestyle that could help the process? And the answer is, that's a tough one there too, because there are a lot of folks with a lot of opinions on what that means to be anti-inflammatory. So the first thing is, I do think that there are a number of supplements that are associated with anti-inflammatory. And one of the most basic is omega-3, is fish oil. There are some that are a little more purified and that actually can have some other really significant anti-inflammatory effects, that things that come from actually algae, that different algae that grow in coral. They can extract the omega-3 from that, um, and it's supposed to be, really very, very good for you. There are a number of different peptides that you can see a specialist for, injections, for things that can decrease inflammation. But from a dietary perspective, um, you know, I'm going to tell you my opinion, and there are lots of opinions out there. There's a lot of noise in this space, and particularly in the fertility space, about what's the best diet to be on, what's the most anti-inflammatory diet, and people talk about keto, and people talk about carnivore, and people talk about this, that, and the other. And maybe you've heard me say before that the thing that all these diets have in common is that carbs are usually the enemy. Carbs are associated with inflammation. So the extent to which you can decrease inflammation, and decrease carbs in your life is probably something that's going to benefit you. Now, in my opinion, I happen to think that the Mediterranean diet, is generally what I mostly recommend to people. Um, and it has a lot of similarities to many other diets. And there is no one diet that is most associated with fertility, with successful fertility outcomes. So anybody who tells you otherwise is not telling you the truth. There has not been definitive evidence that any one type of diet is the one associated with best fertility outcomes. But since inflammation does cause problems, inflammation does keep us from getting pregnant, they say the Mediterranean diet is the most anti-inflammatory as it pertains to our cardiovascular system. And when we start talking about things in the heart, this is the reason that most of us are going to die, right? It's because of heart disease. And so anything that we can do to decrease the inflammation that happens in those coronary vessels, we're way better off. And the diet that's been shown to do that is the Mediterranean diet. So specifically as it goes towards, cardiovascular wellness, which is an anti-inflammatory diet, I think Mediterranean is kind of where it's at. At least it is in my opinion. Let's see what else we got here. Hey, Sharmella, nice to see you. Jay Palmero says, Dr. Fink, oh, best physician ever. Oh, thank you. Delivered my 3 boys and waiting for the day he comes back to Miami. Oh my gosh, thank you. Wow, that is awesome. I am so glad to have you here tonight and for you to say such nice things. And my fondest regards to your boys. I delivered all 3. Wow, that makes me feel really special. Thank you. Sharmella says, my baby is 4 months old. Yeah, and I got my period. 4 months old. Dang, Sharmella, boy, time really, time's gone by fast there, hasn't it? I got my periods last month, and I'm breastfeeding, but this month I didn't get my periods. I'm pretty sure I'm not pregnant, but what would be the reason behind the delay in my period? Well, as long as you're breastfeeding, you may have some irregularity in your cycle. And that has to do with that prolactin hormone we talked about a little bit earlier. That the prolactin hormone is what stimulates the flow of the manufacture and the flow of breast milk. And so as long as you are lactating, that may prevent you from ovulating. And if you don't ovulate, if you don't release the egg, then you don't get the signal of when you're supposed to start, when you're supposed to stop as far as the periods go. So I would say irregularity during breastfeeding is a very common and a very normal thing. Now, and by the way, it's so common and so normal that we know that breastfeeding is partially effective as a method of contraception. That is, while you're breastfeeding, it is much harder to get pregnant. That starts to change at around 6 months. after 6 months of breastfeeding, spontaneous, return to spontaneous ovulation happens a lot more frequently. So that's why we tell people don't rely on breastfeeding as the sole preventative for getting you pregnant. But gosh, Sharmila, wouldn't that be great if you got pregnant on your own now? But I really don't want you to be pregnant at 4 months. That's a little too soon, and that's associated with some higher risks in the pregnancy. So don't do that. Hi to Jaspal. Good evening in Tallahassee. So New Life Fertility had an office in Tallahassee, but we no longer do. I'm located in Pensacola, and we're happy to do a virtual consultation with you since we had a large presence in Tallahassee for many, many, many years. Many years. They just closed the office this year. We see a lot of patients virtually. In fact, we can see you virtually from all over the country. We actually have the ability to do treatments there in Tallahassee through outside monitoring. Our closest office actually for physical showing up and being there is in Panama City. But we're happy to talk to you just on our website, which is fertilityleaders.com. You can click on the link to get some more information on how to make an appointment. And I'd be happy to see you. That's wonderful. You've been trying for 2 years. So far, no luck. Luck is in your future, my friend. I can feel it. I tell you what. Let's see. Pleasant Hill, howdy. Hi, baby love in Florida. Girl, nice to see you. Haven't seen you for a little bit here either. Let's see. Mrs. Villarreal sent a bunch of hearts. Thank you. That was nice. Oh, and Carly said, gosh, we were talking about the miscarriage and the biochemical pregnancy, and she says they were in fact both euploid embryos. So those both being tested embryos means that now we're at a situation where you probably should still be pregnant. That should have worked. So the next thing I would look at would be to say BCL6, and you said you did test that BCL6. And the CD138 were negative, and I am on Prograf. Good, that's Prograf is tacrolimus. I would also want to know about things like your anti-nuclear antibody, your anti-thyroid antibodies. I would want to know that your thyroid hormone is functioning normal without having an autoimmune response to it, because that's something that I would want to treat as well. So I'd be really tempted. So, you've done the right tests there. I'd be really tempted to kind of want to throw the book at you from an immune standpoint and really just make sure that there's nothing going on in your body that's preventing these embryos from growing. But you did the right stuff there with the Receptiva. That would absolutely be next. Amber says, canceling my Botox appointment now. It was 2 weeks before transfer. Well, fortunately for you, you don't need Botox, and you may want Botox, but do you need it? Now, I, on the other hand, need Botox, and that's a different story. You can go ahead actually and get your Botox. Florida Girl says, yeah, I wouldn't do it less than 8 weeks out. I'd say 6 weeks, 8 weeks. All right, you're being extra cautious. 6 weeks, probably even 4 weeks is okay. I wouldn't do it the week before, because there's still, the Botox lasts in your system up to they say about 3 months. In most people, it actually probably lasts at the level of the muscle blocking the receptor a little bit longer than that. So you may get a little longer effect from Botox without having some of the byproducts of the toxin still in your body. But the fact that it's in your body, 6 or 8 weeks later, means that it's localized to the places where it's supposed to be, which is in those muscles in this area called the glabellum, and in the forehead and different places around the face. Let's see. Can I take CoQ10 while breastfeeding? The answer is absolutely you can. Yes, you may. Florida Girl asked, how safe is ammonia-free hair dye when in the first trimester? I need to dye my grays, but I'm too scared to do it. Well, so here's what I would always tell folks about about dyeing hair. First of all, if you could highlight your hair, I don't think there's any risk whatsoever. Now, that said, I'm not really sure there's much of a risk at all to dyeing your hair, but I always told people, look, just use organic dyes. Use the organic dyes. I have never seen a birth defect or a bad outcome that anyone has ever been able to point a finger and say, oh, that's because she got her hair dyed. So I think it's okay. Ask for, and ammonia free is a good thing as well. Ask for the organic dye. Okay. Hey, Mattia, I think that says Liz Carmen. Shadia says, how painful are hysteroscopies? What should one expect? In general, they should not be painful. So we do hysteroscopy here in the office. It's a very straightforward thing. It's a very tiny little camera that goes through the cervix into the uterine cavity. The process really takes just a few seconds to take a look. Now, what we do here in our office is that we also use that opportunity to check to see that your fallopian tubes are open. So many of you have probably been through what we call the dye test, or the HSG, the hysterosalpingogram, which is where we put some dye inside the uterine cavity and push that dye through the fallopian tubes while taking some x-rays. That is a painful test. There's no ifs, ands, or buts about it. It hurts. Now, some people do better than others. Oh, Shady says, mine's tomorrow with you and I'm freaking out. No, don't freak out. It's okay. You really don't have to. What I tell people is that it may be a little bit crampy. It's usually less than what you would have with a menstrual cramp. Now, my recommendation, no matter what we're doing to a uterus, even if it's just a pap smear, is maybe think about taking some ibuprofen beforehand. So take 800 milligrams of ibuprofen. If we're doing it in the morning, take it with breakfast. If we're doing it in the afternoon, take it with lunch. And what that does is that it helps to chase away the crampy spirits so that they don't even show up, instead of waiting for you to get really crampy and then trying to make those cramps go away, because that is not a very good strategy. The hysteroscopy should not be a painful experience. Oh, but I started to say is what we do with the, since we're using a little fluid to look inside, whenever we use fluid, there are always air bubbles. And so we will see those air bubbles float into the openings of the fallopian tubes from the inside. And then we can show, that tells us that your tubes are open and you don't have to do that really painful HSG procedure. So it's a much kinder and gentler way to do that. And that's what I am fond of saying. But no, it should not be, something that you will need to fear, or that is going to be painful for you doing it. And in fact, an office hysteroscopy, if you're just looking, without the tube part, it probably takes 5 or 6 seconds. I mean, it's really very, very fast anyway. So don't worry, we will be gentle. I promise you. I want to just mention one other thing here to Carly, who we talked about had a miscarriage and then a biochemical pregnancy with 2 euploid embryos. The one thing to say is that, we lean on chromosomally tested embryos as if it is an absolute, and it isn't necessarily. Because that testing is not perfect. We can't know for sure. They're testing from the portion of the embryo that becomes the placenta. They're not taking a piece of the baby. And so it's possible that the placenta can be normal, but there's an abnormality in the baby itself. There is also, a situation here where we're saying, well, we suspect that the chromosomes here are normal, but we can't really say anything about the millions of little biochemical equations that happen inside that embryo every minute. And any one of them that goes wrong can change things. So The other thing is about um, the recurrent pregnancy loss labs. I do think that panel of laboratories is a reasonable thing to check. However, um, in most cases, the things that cause that are things that typically cause, pregnancy losses a little bit later on, more often closer to, kind of 9 to 12 weeks of pregnancy. It can be earlier, but I'm not surprised that those are negative. My money is going to be on either something that is autoimmune, something in your immune system, or simply an embryo factor. Now, we do know that by the time you transfer embryo number 2, you have about an 83% probability of a pregnancy. By the time you transfer embryo number 3, you're at about a 96% probability of pregnancy. And you can say 83% is pretty good. By 2 euploid embryos, I would expect, you to have a positive pregnancy test, but you did twice. So ongoing pregnancy, I feel pretty confident the next one you're going to get there. But, just statistically, but you do want to dot those I's and cross those T's. Shayna asks, is the body able to fix a triploid embryo or a segmental abnormal one, considering the body sometimes repairs some problems? So triploidy is when there is a third chromosome. And I think that one may be a lot more of a stretch for the body to try to fix triploidy if it's in all the cells. But a segmental, what's known as a segmental aneuploid, yes, I do think the body has the ability to repair that. And there is some pretty good data that tells us about pregnancy rates for segmental aneuploids. And you would be surprised they're actually a lot better than you would think. And that, I believe, goes to the body's own DNA repair mechanism. So, yes, I think so. Now, if you're talking about, and what I'm talking about here is transferring a segmental aneuploid. If you have a triploidy, like a trisomy 21, for instance, I wouldn't transfer that embryo. And in fact, I don't know that there is a clinic around that would allow you to, because the risk is too high for having a Down syndrome baby, which we would prefer you not to have. Hey, Red Bear, nice to see you here this evening. And why in IVF with ICSI does a triploid happen? Do they not ICSI only one sperm into the egg? Yes, they do, but triploidy is happening due to an error in the way the cells are dividing. So with ICSI, you're taking one sperm, which is a single cell, and you're putting it into one egg, which is also a single cell. Those cells, those two individual cells come together and they start dividing. So triploidy is happening when that division occurs, and that's called mitosis. When that mitotic division, there's an error in that division that the body doesn't correct, and so it starts manufacturing that chromosome as having that gene is having 3 chromosomes as opposed to having 2. It is not specifically related to IVF and certainly not as a cause of ICSI, but rather it happens really randomly whenever sperm comes together with egg. And a special shout out to MCRM Fertility this evening, where I will be later this week up in St. Louis, helping those wonderful, wonderful people and wonderful patients out. Wonderful staff, wonderful patients. I'll be there helping them out with retrievals. We've got retrievals here in Pensacola this week, so it's a busy week. And I want to say thank you so much to everybody for being here with me tonight. It makes my week to spend this time with you, and I'm so happy that you are willing to take this time with me. The fertility business is not the book of your life. It is just a chapter. And what are we doing? We are here to rewrite that chapter together. Every step forward with love, every step forward with kindness. Do something nice for a stranger, would you? and every step forward with hope, knowing that tomorrow, my friends, is a new day and it's full of all new adventures. So until next week, I'm Dr. Randy Fink in Pensacola, Florida. Thanks for being here. Good night. See ya.